don't screw it up.
You're listening to the PT Pintcast, where smart people in healthcare come to make noise. Here's your host, Jimmy McKay.
She spent over 4 decades helping kids move better, think sharper, and live fuller lives. With a heart for mentorship and a clinic full of purpose, now she's pouring her energy into helping the next generation of PTs recognize the huge functional impact we can have on conditions like dyspraxia, EDS, and executive functioning challenges. She also once ran a backyard empire of 78 guinea birds. I'm not 100% sure if I know what that is. I'll have to Google it. But these days, it's all about growing clinicians and not just birds. Cheri Woodson joins us on the show right now. Cheri, welcome to the program.
Thank you.
Are there any guinea birds within arm's length that we could see? I mean, I'll Google it later, but what is a guinea bird? Can you describe?
It looks like a chicken.
Got it.
Out of Africa, but
Okay.
they eat a huge number of ticks, and we have a huge number of ticks. So
these were operational. This was a purpose. They were not just look cute, but
absolutely
eating ticks. All right. So I mentioned in your intro, and before we hit record, you said your real passion is treating, but really it's mentoring and creating more leaders. What sort of prompted that? You know, where's that come from you, and what does that give you, and what do you think it gives the future of our profession?
I think what prompted that is through the years, often worked next to individuals that, kind of poured into me and I could pour back into them, and realize how that made me a more well-rounded clinician. It allowed me to look outside the box. I got questioned, which makes you, not step. I guess it makes you step back, but it makes you delve into information more. And then also saw how the population that we could serve was either changing, or maybe I just didn't see it initially. And so wanted to share that so that the next generation could also kind of learn from both my mistakes and those successes out there.
Sure.
And kind of speed that critical thinking part up. I know I'd read a research article that talked about it took 5 years for the average PT to become a really critical thinker in their practice. And I was like, how can we speed that up?
Yeah.
And we've really operationalized it, not so much me, but my executive team of how, what are all the steps that need to be taken to do that?
So what are they? Or big picture, what are a couple of the big levers that you see from the mentor side, knowing that there's going to be some people out there going, yeah, I want to do this, but also the people on the side going, how can I improve? So what are those things that people listening now, both mentors and mentees, or potential mentors and potential mentees, can focus on? Where's the biggest lever?
I think one is, there's so much that has to be taught in PT school.
Yeah. Why?
And then translating that to practice. So they may have gotten a clinical experience in pediatrics. It may have included a vast population. It may have included a variety of diagnostic groups, but the chances are also that the clinician they were with I think the requirement is 1 year of experience before you can become a clinical instructor. And they may have really specialized in an area. So then going through and looking at what are those core proficiencies that they need, and operationalizing that, listing those, looking at all the other elements that go into, I think, serving children a little different than serving adults, of working with caregivers and listening to what the problems are at home, and then, being able to provide clinical or caregiver education, caregiver coaching, I think is a better word. Coaching and collaboration is what we do. Is we have to know what we're doing and why we're doing it.
Sure.
And what our hands are doing, and what are the things that make being a parent more successful, or make them feel more successful, which is different than being a therapist. Like what part of that? I don't want to make them mini therapists or the parents mini therapist. And so, you ask a therapist and they're just a new therapist is trying to kind of share what they just did.
So you're setting you up. This was my next question on the list. How do you help families understand the need for therapy when a child might not have a formal diagnosis? How do you approach that? What's the conversation like? How do you even start a conversation with someone who's like, well, we don't have a diagnosis? So where does this start? This is a communication issue.
It's a communication issue. It's what I love to do is help. Like if I get a 4-year-old, I can almost kind of share with the parent what they look like at 1, 2, and 3. That was different than what most other parents' kids look like. So you can kind of go, so then they're going, oh yeah. And so you can share what probably the future might look like and where the little building blocks or how their child may process information differently and so we kind of go through that. I think that's a real buy-in for parents. I also sometimes do the same if I'm treating torticollis, which is I call it the gateway diagnosis. It's a gateway into, yes, it might be sternocleidomastoid tightness, but I would say that's not that many of them. That's where all the literature is going to be on because that's a homogeneous group that they can pick. But it could also be hemiparesis. It can also be that they just got some tightness from sitting in those like container, the container babies that we have now. And so we kind of go through that. And I usually go over and show a parent on them, like, okay, if I put you in this position, what does it change for you? And so it's been fun recently, probably in the last couple of years, to also look at how something so simple as a little tightness of the capital extensors impacts a mom who's trying to nurse a baby at usually about 4 months, and how they sometimes have to give up at that point because of all the changes that go on. Like moms don't hold babies' heads as much, and we expect as the breast empties, the baby to make all these tiny little adjustments. But if they have tightness, they can't do that. So they start pulling off. And you're going, oh, well, that was maybe 2 visit,
Sure.
change this week, and then they have it. So the other one would be looking at dyspraxia and that's probably a word that PTs may use or may not use, but we look at a group of kids and they're not moving. And why aren't they moving? They don't have cerebral palsy. They're not moving. And we start looking at it and going, okay, we can see this at 4 more. What is that? And that's that kid that I call it like the deer in the headlights sometimes. You see them wanting to do something, but they can't do it. And I've gone, so we break that down and start looking at that with new clinicians. I often say, what if we could go to a playground, a recess, and go, okay, all these children that are circling the playground, I think they would like to participate. I can't imagine that they don't want to.
Sure.
But what's keeping them from being able to do that? Is it a coordination issue? Yeah, because they feel clumsy compared to the other kids. Or is it they don't have the praxis to do it? You
mentioned PT schools a second ago. What do you think PT's schools miss? They have to teach so much so we can go an inch deep at a mile wide, but an inch deep. Specifically about peds, right? A lot of programs might not have a very robust class just simply because of not having maybe a pediatric PT on staff. So what are the things that you think PT schools could do better?
That's, this is a person who graduated with a bachelor's, remember, as a PT 48 years ago. I did go back and get a master's at the University of Kentucky just because I wanted to know more when I was there, and kind of combined it with took some med school neuro class, they let me in those classes and put some other things together. And there's a personnel prep grant that was out there looking at how do we serve children. And so I went through that. And so I sometimes am like, I get it that there's so much content that they need to share. I wish there were more internships for people when they got out of school. I wonder if, I don't know, man, you go to school forever as a doctor. I have a daughter who's also a PT, pediatric PT, very strong in ortho. And I'm like, what would I change for them?
Yeah, sure.
I wish there was a great answer to that, because then do you take away from the ortho? Do you take away from that? I think it's the clinicians in the field. We have to think more robustly about those individuals who come to us and want take a clinical, an 8-week clinical, 10-week clinical, or 12-week clinical, which whatever the schools have. And that, because we've put that together at ours, and I know a couple other clinics that have done that as well, where we try to mix them up with other therapists so that they have the opportunity to see a larger group of types of patients. I haven't looked at what the APTA is requiring within the curriculum now. Mm. I mean, I know it's a really robust group of objectives that I even do for the PTA program. So I'm like, I can't even imagine what they're doing there. But I think it's trying to, I know they go across, they do those lifespan things. I mean, I think I would have fun going in and talking to an ortho group about all the orthopedic changes that go on during the first 2 years of life, and if development isn't occurring quite right, why you would have why you might have tibial torsion issues, or why, which tells me, likelihood, if it's not hereditary, of what muscular pulls weren't on the tibia. Same thing with the hip. Our hips starts out with very small amount of angle. What are the developmental things that occurred during that time with adductors pulling it down so that the angle, is it increased or decreased, and the femoral anteversion kind of changes that go on. I think that's the part that I would love to see kind of woven in. And it's exciting, because if you're an adult PT, you go, oh, I bet this has been a long time issue.
Sure.
And they have a different biomechanics. Could I put it that way?
Yeah.
So those are the kind of things that I think could be interwoven more successfully for both ends, for the peds therapist as well as the ortho at the other end.
So Cheri, you've seen decades of change. But what's one myth about pediatric therapy that's still around that we've outgrown, that if you could just bring on the eraser, you'd remove? What's the thing that comes up the most that you wind up correcting pretty often?
I think it's probably looking at a skill and not breaking down it's just looking at, like you said, when we were talking earlier about making it fun and that it's play, but being really purposeful in that and thinking, I always think, so I don't always see it as purposeful. Like, what am I doing that's going to make a difference in this kid for tomorrow, or in the family and their engagement? So I think that's a myth of thinking, okay, I can just take this child and I can play with them and they're going to have a great day. And yes, we're going to work on a skill, versus going through and going, all right, like why is this child not progressing? Or if they don't make the following changes, that we're going to see a group of problems, a different kind of group of problems I think it's getting down to the real etiology of issues. Like, why isn't that kid moving? Is he dyspraxic? Is he weak? Is he tight? And addressing that, and they should be treated very differently.
Understood.
And I think I don't know if that answered your question. I think we know a lot more now than we used to, and I think
listeners love strategies and takeaways, specific things, right? What are 2 things they can do tomorrow, maybe to better support kids with motor planning or executive functioning challenges, the kids you have the pleasure of working with your organization? Two things real quick.
And I probably do dyspraxia, and I'd look at praxis and think about yes, they cannot ride a bike, or yes, they cannot go and look at a piece of playground equipment and just go get on it. I wouldn't go put them on it. I'd really start thinking about, like, what's the plan? Where do they need to be helped as far as sequencing? It's a processing issue versus a body structure issue, right? And I think that's looking at things that if I should have given you an example of a play, looking at a play structure and going, I can't just model how to do that. There's 20 kids going up and down, and this child can't do it. Mm-hmm. And so it's going, okay, how do we go through that and teach them each part of that, but then also giving them a chance to process that and not let them get stuck in it. And I always think dyspraxic children, I always go and put my hands on them. And as soon as they look at something and they even indicate there's an interest, I help them see how their body can engage with that. Because they don't have imitation skills, and we don't, sure. And that's something we can't even imagine. So that body awareness part, and then breaking sequences down for them so that they're successful. Does that make sense with that?
Totally.
Because you do have to put your hands on those kids, and you have to do it quick, because that sometimes we see them twirling their hands and twirling their feet, and we think, oh, that's autism. And it's like, I would say majority of children with autism have dyspraxia, but not all children with dyspraxia are autistic. And so realizing that sometimes those are communicative behaviors that I can't figure out what you're doing, and what I have in my repertoire is these repetitive movements.
Cheri, we have a tradition on the show called the parting shot. Are you ready for the parting shot?
Go for it.
This is the parting shot. One last mic drop moment. No pressure, just your legacy on the line.
The bar's low. It's not high, just your legacy.
Yeah.
But what's one thing you'd want to leave with the audience as we wrap up? What's the thing you'd want them to take away, right? We remember the last thing we heard typically.
What would I want them to take away? I would say to really utilize everything in your repertoire of treatment strategies. And if you don't have a large one, keep working on that, and look at how people are using eSTEM, and how they're using, I don't like to, some reflexes, and go, is there something different than inhibiting that? Were they there? They were there for a purpose. Let's figure out what that purpose was. And people have done that, and use that to help children. And I'd say never get stuck in a box. I think that's something that has made probably why I'm still a practitioner after 45 years, is that there wasn't a box that I got stuck in, that there's always something new to learn. And whether that's from another clinician, or from a child, or from a new therapist. I always say, who's the kid that taught you the most this year? With clinicians.
It's a great question to ask.
So that's one of my most enjoyable things, is go, who taught me the most?
It's a great way to look at it. Cheri, appreciate what you're doing. for the people that you get to do it with. And by people, I mean kids, parents, other PTs, the local community. So thanks for doing what you're doing in your little corner of Arkansas.
Thank you.
That's it for this one, but we're just getting warmed up. Smash follow, send it to a friend, or crank up the next episode. Want to go deeper? Hit us at ptpintcast.com or find us on YouTube and socials at ptpintcast. And legally, none of this was advice. It's for entertainment purposes only. See, Keith, we read the script. Happy now?